remember. I think, oh, you know why I don't remember? Because I was on my phone.
Yeah.
Hello, everyone. It's the top of the hour. Welcome to our ECHO session today, implementing telemedicine and other virtual care services during COVID-19. The purpose of this ECHO session is to introduce you to the steps required to implement telehealth services and chronic care management to ensure sources of revenue during COVID-19 and beyond. I'm Trudy Bearden, Senior Consultant at COVID-19 Health, also a clinician and prior clinical manager, which makes me incredibly appreciative of the work everyone is doing, especially at the front lines, to keep everyone safe, expand access, keep your doors open in these trying times. We know how incredibly busy you are during this challenging time, and we super appreciate your participation today. We know many of you are considering or may have already implemented telehealth services in your facilities. Let's get going. All right, so we are, okay, so my scroll bar is really touchy. So in the setting of COVID-19, where also a lot of us are using Zoom, you entered the session muted. And when it comes time for discussion and questions, you just need to unmute yourself. So check out that bottom left where you can see the mic with an arrow through it. Just unmute yourself when it's time to have a discussion and ask questions. You can also type a question into chat, and that is also located at the bottom of the Zoom screen. Chat will be moderated throughout the session today. And if your video freezes at any point, you may want to consider turning your camera off. We find that to be helpful. Right, so welcome. Share and chat. Introduce yourself to everyone by entering your name, organization, and email into chat. We don't have a ton of attendees on the call today, but still really nice to see who's on the line, and sharing your email address if somebody wants to reach out to you because you have the most awesome idea ever. It makes it easy for them to contact you. And as a reminder, we are all teach, all learn. We find that some of the best information is not actually from our presenters, it's from you guys. So we encourage broad sharing. This is our incredible team at COVID-19 Health. I'm so proud to be joined by them today. And these folks helped put this session together. They will be sharing their telehealth expertise with you today. And of course, there are many others behind the scenes. So what are we going to cover today? Oh, sorry, one reminder, the session is going to be recorded and we will share recording and slides to all registrants at the conclusion. So we'll have about 25 minutes of content to review the steps required to implement telehealth services. And also, as I mentioned before, to capture that important revenue while expanding your services to patients and keeping everyone safe. What we've heard is that a lot of our practices have seen a decrease in visits by 60% or more. And I think that's what Mike really wants to get to make sure that we capture any possible chance of revenue. And also, I want to remind you that we are a nonprofit quality improvement organization, always seeking to improve. So we need your feedback on what went well today, what could have gone better. And so we will post a link to the evaluation in chat, but due to that enhanced security with Zoom, you're going to have to copy and paste that link in your browser. We'll also send the link to the evaluation with our slides and recording. All right, so I hope everybody's paying attention. We have a poll for you. So everyone who is on the line, once Bree launches the poll, in what setting do you primarily provide services? So if you provide services in two places, which one do you provide care primarily in? All right, Bree, I think everybody's had time to make their choice. Can you show us the results? All right, so primary care winning out at 33%, followed closely behind by long-term care. We also have folks on the line from the hospital setting, dialysis center, behavioral health, and something else, which hopefully someone has posted into chat what that other is. And I'm turning control back over to Mike. Mike, you are on. And just a word, Mike is our Vice President of Improvement Science, and he's going to be talking for about 25 minutes, and then we're going to have a great discussion. Mike, take it away.
All right, thank you. Vice President of Improvement Science, that should come with a warning that unlike Trudy, I'm not a clinician. And much of what I'll be talking about is some technical details associated with some options that are now available to us due to changes in payment policy, and then some practical ideas or what we've found for implementing telemedicine, telehealth, other virtual care services. By way of what we're thinking about when we're thinking about implementing today, Trudy started us going down this path. I suppose implementation in these days might include as much as if one does one smartphone to another, and FaceTime is on, or some approved technology or platform is used, and you do it once, in some sense you've implemented. But that's not where we're heading. What we're trying to do is support and to learn how practices, providers are implementing such that this becomes a viable way of providing care, that we are able to replace what were face-to-face services with telehealth to the extent possible, the extent that the technology allows and the sound practice allows and things like that. But we're going to actually start exploring a little beyond that. It's one thing to replace what we were doing before with telemedicine or telehealth. We might also want to think about how can we use the technology that's available in the circumstances we find ourselves to develop new implementations or new practices that better address the needs of our population currently. So we're going to be talking about that as well. And as we go along, questions, reservations, things you want to clarify, we're going to have lots of time to stop and talk later on in this session. So if you could start putting those in the chat. In fact, Trudy or someone else might decide that it's crucial enough to pause, and we'll address that. But if not, we'll have lots of opportunity to talk later. Again, issues, if you put them in chat, we'll make sure we get to them or try to get to them. So here's what we're doing. Using our technology, communications technology for non-face-to-face care. Not everything we'll be talking about, but some of what we'll be talking about is specific to Medicare, at least the payment rules, and specific also to COVID-19 waivers. So why are we doing this? Again, infection control. So avoid the risk of disease transmission, improve access to care, possibly improve access to care over what we've had before, and to keep the practices and organizations financially viable. And we're very much interested in hearing from you, your experience using some of these modalities, questions and challenges. If there's other ways that we could serve you, we'll be wanting to talk about that. So it's a long list of disclaimers. Everything that we're going to review, you have to understand in terms of your circumstances, your license, your state, your local regulations. We have folks on from multiple states here, and there may be different rules for them. Your own malpractice carriers, your own professional judgment about what's appropriate, those sorts of things. So again, I'm neither a lawyer nor a clinician. So what we talk about, please take in that context. So this slide, one other warning. There's a lot of information on all the slides we have here. I'm not going to review all of it, but we wanted this to be available to you. These slides are going to be available after the session. So if it's going faster than what we review, and we can either come back to it later on or know that it'll be in those slides. There are at least a number here, 8 types of virtual care services that are payable under Medicare. We're going to be talking today about, we're primarily going to focus on telehealth, and then we'll talk a little bit about care management, and I'll remind you of why we're connecting those ideas when we get to that point. So to begin with, telehealth. Telehealth implementation and use. Reminder, what is telehealth involved for Medicare payment? Involves interactive audio and video telecommunication technology and the use of that. And what we'll be talking about today are the activities of what are called distance site practitioners. There's also the possibility of what's called originating site, and we won't talk about that much today. So, overview of what telehealth looks like under Medicare. And again, our review indicates that other payers are generally following these type of practices. But you got to confirm that specifically to a payer. But for Medicare, there are approved services, has to be interactive audio and video. There's something called distance site practitioners. These are the professionals providing the telehealth service. And before COVID-19, under Medicare rules, these benefits were largely, if you looked at the policy, you looked at the way it was implemented, it was to address the problems of access for rural and health professionals shortage area people. That's why the benefit was allowed. Well, under COVID-19, the rules changed. So this became an infection control strategy, so that we could reduce the risk of face-to-face encounters. And those waivers, so current rules, allow for telehealth for patients in their homes or any healthcare facility, regardless of whether that's urban or rural. It has also expanded, so we've switched slides here. I'll mention this. It's also expanded to allow for that type of infection control, the range of services that are allowed. Before the COVID-19 waivers, there were 100 services. There were important services. There was a wide range of them, and that's been expanded substantially. So if you knew the benefit, or if you knew the rules on January 1st, know that they've changed. And later on, we're going to provide resource. You'll see some resource slides, including links to the full list of services. Many of you, perhaps all of you, know that those providers, the practitioners that can provide telehealth services include physicians, nurse practitioners, physician assistants. You see the lists, including social workers, clinical psychologists, nutrition professionals. So a wide range of services are allowed now. The types of services that are included in this include office visits, it includes psychotherapy, behavioral health, but I've highlighted it includes preventive care. So it offers the opportunity that we don't have to wait for a problem to arise, or a patient to initiate this for some problem that has come up. We can let patients know that for folks in primary care, that these services are available and can be provided. The payment substitutes directly for an in-person. It pays the same as face-to-face. It's paid under the physician fee schedule. And under some exciting new developments, the federally qualified health centers and rural health centers can serve as distance site providers, practitioners in essence. So so here's a little bit more about the technology itself. The types of telecommunication, the technologies that you can use include certainly things that you would recognize as dedicated telehealth platforms and equipment. You may have seen carts with cameras and other devices attached to those, and those are certainly still allowed. But at this time, it is allowed to. You could have things as simple as telephones with audio video. My phone even has this. The smartphones, tablets, laptops, those are all allowable. The communications, now I'm saying this and hearkening back to the disclaimer side. The way we want to use these things is still consistent with best practices in security and confidentiality and protecting patient information, but the devices themselves include these that are listed. So it's allowable to, there's a waiver around what's called good faith use of everyday telecommunications technologies like FaceTime or Skype. Our team has done a review of this, and we think that in most cases, this shouldn't be necessary. That is, although it's allowed under this good faith waiver, and in fact, upon review, you may find it necessary. We think that once we're past the immediate emergency phase, or even as you're instituting it, you should be able to find an approved, or not approved, a compliant platform that meets your needs. We'll talk about a couple of examples here in a moment. So, but that leads us to selecting a telehealth platform. So how are we going to institute this? Maybe we'll at first use a FaceTime or Skype in good faith, but we want to plan for a little bit of the longer term. And that actually leads to a question. I mean, how much of a long-term solution do we plan for? There's a great deal of speculation about what will happen after the public health emergency ends, to the waivers and to the benefits and to the payment for telehealth services. I'm not going to predict the future, but I'm going to suggest that at least where it's relatively inexpensive to make choices that prepare you for the long term, it's probably a good idea to do so. If you're contemplating significant capital investments in order to implement telehealth, it would be wise to at least consider in those calculations the possibility that the rules will change when the public health emergency ends. Indeed, the waivers that we talked about already, they are, the way they're written right now, they sunset with the conclusion of the public health emergency. So that's what we know today. Things change all the time. So what have we heard in terms of, if you haven't already settled on a telehealth platform, we're hearing that it's worth reviewing solutions that are either part of, integrated with, or compatible with your electronic health record, either what you have in place already or what you're planning on going to. So that's a good place to start looking for that. If we're planning beyond the good faith use, we're going to want to look for HIPAA compliant features, and we'll note that there are a range of options available. There are some specific things that are not allowed that just don't have even the minimal security features, including Facebook Live, Twitch, and TikTok. And I have to confess that I'm just reading those words. I don't actually know what those mean. I don't intentionally Twitch or TikTok. So our brief review, and we looked at and including looking at what professional associations and others have identified as examples that may merit your consideration. We're saying that without endorsement, we're not advertising, but these have, and we've gotten good feedback from folks we've talked to, that these are worth considering. Something called DoxyMe, Simple Visit, and Zoom for Healthcare. So that might provide a good starting point for your search. And then again, your EHR vendor is probably the first place to start in terms of they may have an integrated solution or solutions that work best with their platform. Oops. So as we do this, what are we going to find? We're going to find with every technology some challenges and barriers that we encounter. One that we're hearing about is our system, our IT system locally wasn't built to handle this load. That is, we didn't install the bandwidth to conduct, multiple telehealth visits simultaneously. This is a real thing, and you can't talk a system into handling a bigger load. You either have to find a way to manage those simultaneous interactions, or upgrade the system. So those are elements of the system that might have to be fixed with technology. Also, I mean, another element of our practice system, if we think of the system broadly, we've never needed to know how to bill and code for these sorts of things. We might have to learn how to do that. Another barrier that we're coming across is the patient's home as the originating site. So now telehealth is possible, it's available, we're ready to do it, but the patient in their home either has no device, or their connectivity or bandwidth is limited, have limited data plans. We're interested in hearing about how people have addressed that. So we'll have an opportunity to talk about that. Sometimes the barrier is another originating site. We have a patient in a nursing home, and we'd love to check in on them or see how their care is going, that sort of thing. But the nursing home themselves aren't set up to do that. That we've heard is a barrier. Dialysis facilities there's some services that are now allowable for a patient in a dialysis facility that weren't allowable before, but the facility might have to be set up in order to do that. So we'd love to, again, hear more about your experience and what you're seeing on this. Those are the rules. Those are the payment rules. We talked a little bit about the technology, but you still got to put this into practice. So, and what have we come across? We've got some toolkits, or a toolkit or two on our website, our resource page, that we're going to refer you to in a moment, or let you know about. The types of things that you see in these toolkits is a type of good implementation practice that we see for other types of changes in your workflow and things like that. Beginning with, to be successful and making this a regular part of your practice, it's going to involve the entire practice team in the implementation. So just plan on that. You'll have good ideas on where to start and how things should work, and those good ideas will be improved by involving everybody from the schedulers, the MAs, to everybody that might touch this.
So Trudy,
So it looks to me like Mike's screen froze. I don't know if he's having internet problems. And I am not sure that I can take control. So while he gets his technology sorted, I wanted to share. Okay, so it looked like Sandra, you got kicked out as well? Or no, that was early. Okay.
Yeah, earlier I was kicked out.
Oh, so Mike, you're back.
Yay.
Hello.
I'm back. My apologies. I think I saw where I got kicked out. And again, my apologies. I'm going to try to pick it up from there, if that sounds right, unless you've developed another plan while I was away.
No, you were on slide 19, I think.
All right. Does this look familiar?
20, slide 20. Yep. Mm-hmm.
Okay. All right. Good. Okay. So again, we have implementation toolkits. In fact, I think that we've completed the development of an example that you can use of a brief patient education communication material, so you can send to patients of what to expect from these visits, that sort of thing. That's on our website as well. I really want to emphasize this middle bullet point on scheduling. Our understanding, talking with providers, is that, again, so we want to use telehealth for a number of purposes, not only to reduce for better infection control, but also to maintain quality patient care. And we're hearing that there's the pressure or the direction that this moves in is that patients, given the option, may elect something less than that full telehealth experience. They might elect or prefer a virtual check-in, a telephone visit, that sort of thing. Those are virtual services, and those are legitimate virtual services, but they pay far less than the telehealth service. And we, under professional judgment, you have to decide whether or not that really substitutes for the type of care that they want, or the type of care that you want to provide. There are things, my understanding is that care experience is simply not the same with a telephone-only visit. So making sure that you are providing that level of care, our understanding is you really have to involve the scheduling process such that we're not substituting a telephone where a telephone E&M visit, for example, where a telehealth interactive two-way audio video visual is what is needed. So notes on billing, and again, we have additional materials on this on the website. It's an equivalent CPT code. There's not different CPT codes, but there's a place of service for telehealth code that's included for Medicare. Other payers, you got to check their rules. Briefly on care management. So the reason we're bringing this forward, this is most of what I'll talk about. In fact, I think everything that we'll talk about here is not actually a product of waivers associated with the COVID-19. This isn't technically it's a phone. It can be delivered by a phone. It's not a telehealth service. But the reason we want to talk about this was that idea of implementation. We've been monitoring the use of care management or chronic care management under Medicare for some years. And in our assessment, it looks like in some places, in some practices, that this might have been underutilized. And maybe it was underutilized in prior to COVID-19, but the conditions have changed such that we think it'd be worthwhile to reconsider decisions about our use of chronic care management given the current conditions. That is, do we want to potentially provide a higher level or additional care management services beyond what we were providing, before the pandemic? So, brief descriptions about what chronic care management is. We'll review that quickly. And then there's actually a new code called, or new service recognized called Principal Care Management that is, it's not restricted to specialty, but the expectation is that most of this would be billed by specialists. This was new. This was not available last year. So briefly, chronic care management, it's a comprehensive services. We have a comprehensive care plan, provide access to clinicians with staff that can access the medical record. We follow up with patients. This can include transitional care management, arranging for home and community-based services or coordinating those care. And these are services that can be provided. A great deal of this can be provided not by clinical staff, and their time is billable to chronic care management. This is so. For example, what's called a non-complex chronic care management, 20 minutes in a month, which might be the level of follow-up that you're providing for some patients. It pays $40 for 20 minutes of clinical staff time directed by a physician or other qualified provider. Principal care management is similar, except that it only requires a single high-risk disease that you're managing. This could be more appropriate for the conditions that specialists find themselves working under. There is a requirement in that case that you coordinate, especially with a primary care provider. There's more information, especially on chronic care management. Principal care management is kind of new on our website, and so we refer you to that. So again, we talked about telehealth implementations and some of the barriers that come up there. We'd love to hear more about your experience there, and if there's especially the experience you've had in overcoming barriers and care management, or more properly, I think, enhancing your care management approach in the conditions we find ourselves in. So that's what we had so far. Oh, again, as promised, we have resource slides. I'm not going to read these, but I wanted you to know that they're there and know that you'll be receiving a copy of this. Place to go, what we thought of as some key resources that could help you if you're building or enhancing your telehealth services at this time. So a number of Medicare resources, the spreadsheet with all the codes, and some more information on chronic care management. I think that, and all of that, by the way, those are direct links to resources. These are also collected along with other valuable resources on our telemedicine and virtual services resources website. So that gets us to this point. I see there's been some action in the chat. Should we go over there?
Yes, well, you know, Mike, I'm a chatty Cathy, so a lot of what's gone into chat has come from me. But for our attendees on the line, this is your chance to chat in questions for Mike. Part of the ECHO model is that we want it to be a safe space. There are no wrong answers. It's okay to speak up and ask questions. I will restrain my urge to call on people because we don't want to put people on the spot. So we won't do that to you, don't worry. But if you have a question, type it into chat or chime in. So Mike, I will say that when I looked at the questions from the registrants, some of their questions were, how are others handling telehealth? And I know that both you and I can provide a little insight into how others are handling telehealth. I think some folks have done some really interesting strategies to make this happen. What are some implementation strategies? What are some of the telemedicine platforms, which you covered? And I agree, I keep hearing certain names of certain platforms keep coming up again and again. How is telemedicine changing and how do we get started? So those were some of the questions that were submitted in our registration. And Sandra said, feel free to show your video and unmute yourself. I don't know how many of you have been on echo sessions before, but when I was on one this morning, crack of dawn at 6 a.m. in Indiana, they had 160 people on the call and almost everybody had their video showing. It was kind of like a Hollywood Squares of Zoom. So if you feel comfortable doing that, do it. If not, you can stay incognito a little bit.
So as we're going, especially if there's anything that we've reviewed already that you want to confirm or didn't sound right or something like that you want to clarify, we can do that at this point. We're also we'll be opening up for more general discussion. So.
You want to move to the general discussion, Mike?
Yeah, let's actually on the way there, we have a couple of polls just to get a sense of where people are at. So one poll the first one is how much of your face-to-face care that can be provided by telehealth have you converted to telehealth? Give us a sense of where you're at on that. I'm letting Bree, she's got a sense of the, all right. So we've got some folks that have converted. And what are we seeing? You know, I've been on a couple of webinars and things like that, talking to other providers. I've heard that 70% is not out of the question, 70, 80%. Somebody's achieved that, or at least at this point. And then we have some other folks that have not converted that much. I don't know if we should talk about that, whether you have plans to convert further or not. Before we go there, though, a second poll about the care management or chronic care management. So similar poll about how many of what you would consider to be your at-risk patients are you following using care management, or I suppose chronic care management? And here it comes. And okay. So a couple of folks less than 20% and 20% to 50%. By the way, I will tell you that in our review of claims data last year, Medicare only, chronic care management codes, the distribution, what we saw was a whole lot of practices were doing none, were doing 0%. And then we had, a number of them that had pretty good penetration. We're getting a lot of their patients enrolled in and involved in that. So that's what we were seeing before this, but everything in the world has changed, so we don't know how current that remains. So let's, so here's where we're at. Now we have, I hope, a sense of the, oops, I'm gonna share just another moment, a sense of what some of the participants, where you're at. But here's what we're after. Let's talk about the challenges, successes, barriers, that sort of thing, how folks are overcoming that, questions that you wanted to follow up, things that we might be able to help with, that sort of thing. So now I'm going to stop the sharing.
All right, so it would be great to hear from some of the practices who responded to the polls. I would love to hear from a practice that is doing more than 70% of your face-to-face care through telehealth. Do you feel comfortable speaking? Just go ahead and unmute yourself. We'd love to hear from you if you're doing more than 70% of your telehealth, 70% of your face-to-face converted to telehealth. And if you're having problems getting unmuted, just chat into us and let us know. Looks like Chris is unmuted. I'm not seeing a mic for Heidi from Rexburg Medical Center. If you're on the phone, press *6 to unmute. So while folks are maybe sorting that out, Mike, we had a question from Seema. Seema, go ahead.
Oh, I think we might have lost Seema, but I'm not certain.
I wonder if people are getting bumped off. All right, so I'm going to answer one of the questions that was submitted in registration. So how are other people handling telehealth? So we've seen a full range. We have seen that a lot of our behavioral health organizations have been doing telehealth visits already, which is great because we have a problem with access to behavioral health. And there are some challenges. We asked one provider, well, how do you deal with having eye contact with your patients? And they said, oh, our patients are used to us not having eye contact with them anyway and typing into the computer. What most sites are doing are, we know from one of our nursing facilities, for example, they're going to use tablets. So they have tablets for doing telehealth. They have done staff training. They have increased the power of their Wi-Fi nodes, which I hope that makes sense to you, but they realized that they had low bandwidth, and so they had to have boosters put throughout so that they had adequate Wi-Fi. We have noted that in the rural areas where patients don't necessarily have good bandwidth, they are sometimes able to engage in a telehealth visit using their data plan. But to cut down on the amount of data that is used, the MA will do a phone call, then turn it over to the clinician who will do what he can or she can on the phone, and then they do just a short piece of the visual part that's required for telehealth visits. And we had another medical director who said she just went from provider to provider to provider and said, here's your Zoom account, here's how you sign in, and walked them through the workflow. So they decided how they were going to do it. But instead of like sending out an email, they went kind of warm training, like here's how you do it. Also, some practices are using their MA or LPN staff that were previously doing check-ins, vital signs. They are backup reinforcement, and they are also modeling the telehealth visits very similarly to our in-person visits. So they're doing pre-visit planning. The reception staff are collecting demographic data, including, are you on our portal? What is your preferred way to connect? Have you tried any of these platforms before? The MA then gathers the necessary information regarding preventive and chronic gaps in care, maybe asking about symptoms, what are your questions? Then even doing review of systems questions. Some of the MAs and LPNs are doing review of system questions, then handing it over to the clinician. Often the MA or the LPN is staying on the call with the clinician and acting as a scribe so that the clinician can have that more direct interaction with the patient. And then when the clinician's done, the clinician goes on to their next patient, and the MA or the LPN will finish up the visit. And it's kind of like we do it in the office, right? So there's, everybody is doing their spin on telehealth. One of the things that we did realize is that there are sometimes configuration options in your EHR that you may not know about. So types of televisits, your vendor may support that, but when you initially got set up, you said, no, we're fine. We're not going to be doing telehealth visits. And there may be features that your vendor has that can help you with telehealth visits. One of the people that we spoke to, for example, they had to do a configuration in their system to bill from place of service 02. So, there are a lot of ways that practices are handling telehealth. I feel as though each specialty, each EHR, each telehealth platform, different types of visits, there's just, people are figuring it out. We've really been impressed. We thought, they're going to come running to us. They're going to really need help for technical assistance. And most of you have just figured it out. If you haven't, now's the time to ask a question. And I'm going to turn things back over to Mike to fill in the gaps or answer a different question from our registrants.
Let's see, I just want to make sure anybody, this is your echo. So I got stuff I would be interested in talking about, but I'm really interested. Is there something you'd like to talk with about the group that's come up? And even if we would like to hear about successes and experience you've had implementing telehealth. We're interested in it, and we think that your colleagues join here on the phone or on Zoom would be interested in and benefit from hearing that as well, if folks would be willing to share. I'll wait for a moment. We'll see if folks would be willing to share.
This is Chris Hollis. Can you hear me?
Yes, thank you. Thanks, Chris.
Oh, I'm only responding because everybody's very quiet, but I may take us in a totally different direction. I was just curious. I actually used to do international work a lot before coming here, and some of the health communication work we used to do, because you had trouble reaching a lot of people, especially out in rural areas or something like that, and you didn't have that many, different types of media and everything. But back to one of the points, Mike, you had noted prevention as another area for us to be thinking about. And interestingly, I'm also thinking the case management part. There used to be very interesting things done with what you might call interactive radio with people, and even using that to teach children, lessons, even math and everything else. What they would do is actually have black space on the radio. You would have the program, they would ask the kids a question, kids had enough black space to respond, the teacher would pick up on the response, a lot of other things. So we used to use interactive audio tapes and everything that were also edutainment for people, but they would go back and forth. And I wonder about the possibilities of using those at all to reach like maybe a wider group of patients. And again, in my case, I think of some of these patients as employees, but doing that kind of thing. I'm also curious, I know that the telemedicine right now is focused on like the face-to-face actually between patients and clinical providers, but I also wonder if there is a way for health plans or even the providers to possibly use the telehealth platforms, or if you will, the webinar ones for, let's say, community health workers or something that are trained to do like the screenings that we're pushing a lot more on to identify social determinants of health, for example, and to be able to do those kinds of things to a wider group where that they could do it through telehealth and reach more people that way, and then provide that information back into, again, the clinical system. I also think there might be interesting things one could do with it around improving health literacy. Even let's say if you had sort of a program of walking a patient through the whole, like you had already started it, for example, with how to for patients who are going to do a virtual visit for the first time. You could kind of walk a patient, or let's say in this case, an employee who might be thinking of doing through it and ask them questions at different times, but navigate them through that and perhaps even a broader process. So I've just kind of jumped off all over the place, but I just wanted to throw out those ideas.
First of all, thank you, and I think that those are very interesting ideas, and at least partially, I think that so for example, chronic care management. When we review the services that are included there, you might see a strong or some overlap with functions that you would say, you know what, sometimes community health workers do that. That's not completely distinct. So coordinating with home and community-based services, that sort of thing. Even the education and health literacy, walking people through their care plans, that's billable under Medicare. If you look at those functions, now there's no, under chronic care management, there's no requirement that you use telehealth, audio, visual, two ways. But if you have a system set up and it doesn't cost you anything, or it doesn't cost you anything more, then I think it makes sense to at least consider using that for those functions as well.
And I think that Trudy had sort of mentioned, I don't know if there's any possibility of creating a product in some way that Comagine could, provide or something. But that is kind of, spreading it a little further. But I do think one should be thinking in terms of care management. There are other members of the team, just as you said, and that would include like community health workers or something like that.
Right. So thank you. Other folks other thoughts and experience with, and again, very interested in hearing your experience, what's working, what you'd like to see work better, and what successes you had, how you've overcome Gesundheit, Trudy, barriers.
All right, Mike, we have a quiet group. So to the folks that are on the line, I shared our website. If you have questions, review what's on the website. We have a telehealth help desk. If you have a question, just forward us the question. We'll get back to you within 2 business days, most likely sooner, but no longer than 2 business days. And we also are getting ready to launch a feature if you just want to talk to somebody. So if you want somebody to talk to you one-on-one, we'll have an on-demand technical assistance option for you to ask whatever questions you like one-on-one. Thanks, Danielle. Good information today. Thank you all. And if you have follow-up questions, you know where to find us. We are looking forward to our next ECHO session, which is going to be on May 20th, and that's going to be about remote physiologic monitoring. There's a lot of interest in this topic, and Seema Rather is going to be our presenter for this. As a reminder, we'll send you the link to the recording and the slides if you want to listen to those or use any of the information in the slides. We would really appreciate it if you would fill out that evaluation form. Even though we only have 4 or 5 participants on the line, we improve by feedback. It's the only way that we can improve, is hearing what did we do well, what could we do better. I'm thinking maybe we should have done better advertising so we had more folks on the line. But thank you so much, Mike, for your excellent presentation. We're going to go ahead and end the session. And thank you so much for your precious, precious time today. Have a really great rest of the week. Thanks so much.
Thanks, everyone. Have a good day.